Hello, my name is Mr. Noel Seski. I'm a physician assistant student, and we talking to you today about anterior cruciate ligament tears. So first, we're going to start with the case. 20-year-old female college soccer player, reporting a 1-week history of knee instability. Patient's complaining that after sustaining an injury where she was rapidly changing directions, she felt a pop in her knee, causing her to collapse. Now she's complaining that her knee feels like it's giving out, especially when she's going down the stairs and moving laterally. Patient denies pain, but there's significant swelling. Past medical history is significant for a right ACL tear with a repair with a patellar tendon autograft. So now we're going to talk about the ACL. So the ACL's function is to prevent anterior translation of the tibia. It also prevents rotation of the tibia as well. So we have different mechanisms of action. You have non-contact, which is associated with that rapid change in directions. And then we have that contact mechanism, which is the direct blow. And there's high energy and low energy. Low energy is more associated with sports injuries, like when someone's leg's being held down and someone gets struck on a valgus way. And high speeds associated with trauma from a motor vehicle accident. So epidemiology is 100 to 2,000 torn ACLs with a partial and complete per year. The most common mechanism of action is non-contact, and it's associated with soccer. It affects females more than males, and this contact mechanism injury, which is the second most common, is associated specifically with football. The risk factors are non-modifiable ones are history of previous ACL tear and being female. So our modifiable ones, so you can change your activity because soccer is highly associated with it, or not. Neuromuscular risks are associated with it are hamstring weakness, external rotation weakness, and torso weakness. So signs are usually painless unless you damage one of those menisci. Your knee's going to blow up, it's going to swell. And then common complaint is knee instability, especially associated with those activities that you would normally have, the ACL, so the anterior translation, so when you're going down the stairs, and when you're laterally moving, so the ACL provides lateral stability as well. So our differential diagnosis these are the structures that we need to test during our physical examination that we need to make sure that aren't injured as well, because if you have mechanism injury significant enough to damage or for you to suspect damage to the ACL, then you need to test those other structures. So this is a diagram of what it looks like for the unhappy triad when you have a significant valgus force that causes tearing of the ACL, tearing of the MCL, and damage to the medial menisci. So now we're going to begin our physical examination. So first we're going to inspect the knee. I'm going to be inspecting the knee for any trauma and all the other wonderful things that we need to test for in H&P, but we're also going to assess for the alignment in the knee. We're going to assess for the ankle. We're looking for eversion of the ankle. We're going to look for foot pronation, which can all be associated with ACL tears. And I'm going to inspect it. I'm going to do all these tests. I'm going to repeat them on both sides. That way we have a baseline. We have a baseline to test with, because we don't know whether it's pathology or baseline. So I'm going to first palpate the structures of the knee. So we're going to palpate the patella. I'm going to palpate the lateral joint line, the medial joint line, and the posterior joint line. Now we're going to assess for strength. So you need to do range of motion strength. So we need to test the strength of the knee. So if you extend both your knees out and then pull them back, this is flexion, that was extension. Strength is 5 out of 5. Now I'm asking the patient, please lay down. We're going to assess for range of motion of the knee. So can you please extend your knee out? So extension should be about 0 to 10 degrees. Now, can you please flex your knees? The knee should flex at approximately 120 to 150 degrees. And then we're going to perform our special tests. So first we're going to assess for the menisci by joint palpation. So we're going to palpate the lateral joint line and the medial joint line for the menisci. Then we're going to perform McMurray tests, assessing for the medial and lateral menisci. So first for the medial menisci, we're going to externally rotate, apply a valgus force, and I'm going to palpate for any clunks or tenderness while straightening the leg out. And now we're going to do the opposite for the lateral meniscus. So I'm going to apply a varus force, internally rotate the ankle, helping for any tenderness or clunking. And now we're going to assess the LCL and MCL. So I'm going to support my patient's leg. I'm going to apply a varus force for the lateral collateral ligament, and I'm going to apply a valgus force for the medial collateral ligament, assessing for laxity. Increased laxity would be indicative of a positive finding. So now we're going to perform the Lachman test for the anterior cruciate ligament. So I'm going to stabilize the femur. I'm going to anteriorly translate the tibia, assessing for laxity. And now I'm going to perform the posterior drawer test. So I'm going to stabilize the femur, and I'm going to posteriorly translate the tibia and have my patient's feet on the
flat on the examination table.
Okay, so this is just a quick review of the structures that we tested with, but what tests that we order, and just what their sensitivities and specificities look like. Um, Now we're going to look at the management. So acutely, we're going to manage with RICE, so rest, ice, compression, and elevate. You're going to need a referral to an orthopedic surgeon. Best treatment for most of these patients is going to be surgery. Some patients can be managed conservatively. This is supposed to be reserved for patients with partial ACL tears, which can be treated with PT, rest, and that sort of thing. Or if you have a sedentary older adult that doesn't really move too much, you can not treat it because if you're worried about surgical risk. Next, we're going to look for our prognosis. Most patients resume to similar level of activity, regardless of what surgery is chosen, whether it's allograft versus autograft, patellar versus hamstring. Although there is that significant risk factor of ACL tear. It could be injury to that same ACL or to the contralateral ACL. Rehabilitation and physical therapy will be extensive. The type of surgery performed and damage to the other knee structures are also big factors into prognosis. So our take-home points for our patients: RICE for the acute management of it, referral to orthopedic surgery, and then they may order some additional tests such as X-ray or MRI. And then for the major patient education point is managing expectation. So for managing patient expectations, you want to let them know that although there is excellent prognosis with the surgery, the rehabilitation is going to be significant. You also need to tell athletes that they're going to need to listen to their bodies because they're poor judges of going back to injuries. And sometimes they're going to need to wear braces for any athletic activity. And these are my sources, and thank you for listening.